Good evening, everyone, and welcome in our webinar series of WHO Collaborating Center on Patient Safety Policies and Strategies. This is Samia Al-Ataibi, Senior Patient Safety Specialist in the Saudi Patient Safety Center. Today, our webinar, as known by all of you, is the role of infection control measures in reducing maternal mortality. This speaker will be discussing the following objectives about the types of maternal infections in healthcare facility, assessment of infection control practice and maternity unit, opportunity to reduce maternal and infant mortality related to infection control, frequency and management of maternal infection in health facilities, infection control and quality healthcare regarding the maternal care in the new millennium. The target audience of this webinar is all healthcare practitioners. Our webinar will be starting from now up to 7 p.m. in the local time of Saudi Arabia for 1 hour. And prior introducing our speaker, we would like to ask all attendees to keep their mic mute and to post their questions at the question and answer icon. You can see it near to the chat icon, and the speaker will be happy to answer it by the end of the session. So our honorable speaker today is Dr. Mohammed Halwani. Dr. Halwani holds a PhD in hospital infection control from University of Nottingham, UK, and postdoctoral fellowship in the same field from Johns Hopkins University Hospital in US. He has around 15 years of experience in infection control. Dr. Halwani currently works at Al-Baha University Faculty Medicine as Associate Professor and Consultant in Infection Control and Microbiology. It's a great opportunity to have you again, Dr. Halwani, with us, presenting such an interesting topic.
Thank you very much, Samia, for your kind introduction. I would like to start immediately, and I will share the slide now. I will put the cam off during the presentation. However, I will put it on again at the end of the presentation in case anybody have questions.
Halwani, your voice is cutting off.
Sorry? Can you hear me?
No. Can you repeat?
Can you hear me?
Yes, now it's clear.
Okay.
Stop sharing my screen.
Okay, now I'm sharing my slides now.
Okay. And they'll be off the cam.
Okay. Okay, hello again, everyone, and it's my pleasure actually to give this presentation, and I would like to thank the Saudi Patient Safety Center for inviting me as a presenter for this very important topic. Actually, I can't move the slide. Yeah. So if we just take a quick look on this map, you can see there is different colors, which actually indicate that some countries have high mortality or extremely high mortality in both women and the newborn. And cases, you can see that from the map, like if you notice that the dark blue indicate that in every 100,000 people, there is 100 death happen as a result of maternal complications. Looking to the other color, which is light blue, you can see that cases actually increases from 200 to 299, while the yellow color, the number of deaths increases between 300 to 499. And that number actually keep increasing until it exceeds 1,000 deaths as a result of maternal mortality.
Dr. Halwani,
yeah?
Sorry for interrupting you. The slide is not moving.
Oh, because it moved. Now, is it moving?
No. Can you stop sharing and share back again?
Okay. Okay, is it clear now?
Yeah, can you move to the next slide?
It's not moving even with me. Let me just go back. Okay, is it clear now?
It's clear. Can you move to the next slide? And Hiba at the back end, she's helping us to start
Okay.
from her side as well.
Okay, how is it now?
Okay, you can click.
Is it moving now? Do you see it?
No.
Do you see the map?
No. It's still in slide number 1. Hiba trying to share from her side, and
Okay,
I want
then.
the audience to be patient with us till we fix this.
Okay.
Okay, you may start, Dr. Halwani. You are on the map slide now.
Okay, can you see the slide?
Yes.
Shall I use a slide as my slide, or are you gonna do it?
Well, we're gonna do it. We're gonna move. Now you may continue on this slide.
Okay.
Thank you.
So as was mentioned about, you can see that the different colors of the rate, the number of deaths that happen around the countries, and you can see that different countries have different colors, and that indicate usually the poor countries who have more mortality based on the condition of the country. And this actually might become more critical when patient is from low-income country or remote area. So it's not always easy to choose the delivery place or where we are going to do it. Is it at home or anywhere? You know, some of the villages in some of the poor countries, they can't actually decide where to do delivery because they don't have all the facilities. Although some of the developed countries, like in UK, for example, you can choose to deliver at home, but usually that with agreement with the hospital. So usually that happen under the supervision of a hospital that actually looking after the mother, and of course in the presence of a midwife. But in some of the countries, usually the poor countries, it's not very easy to do that. So delivery can be actually under some conditions which might increase the risk of infection. Can we go to the next slide, please? So the role of the mortality in delivery is actually known. In fact, around 11 women per 1,000 live births had infection, which resulted or contributed in this. And as I said before, delivery is not always in the place you wish, and emergency delivery might happen in different places, and that actually can expose the mother and the child or the newborn to different conditions. So you should need to have a safe environment. And when we say a safe environment, actually should be provided for both the family and the healthcare providers. In whatever setting the birth is going to happen, we have to have the required precautions in order to have safe delivery, and at the same time you have a newborn without any complication. And that usually include the proper aseptic techniques, properly trained staff, and sterile instruments. All are factors that can increase the risk of related infection, and of course associated with death. Mothers and newborns are really susceptible to infection, especially pre-delivery and after delivery, and we have to keep in mind that always. Next slide, please. The thing that a lot of people do not really consider is the construction of the place where you have delivery. There is many guidelines that were put in that, but the application is not always easy. The whole idea about delivery is having a place that have the least risk of infection. So it's very important that we have a delivery suite that match the international standard. But the problem is sometimes in poor countries and countries that don't have enough facilities, it is a bit difficult to actually apply that, and they have to use whatever resources they have. So the place should be prepared at least to respect the communicable diseases that might be present on admission. Some mothers might actually come with open TB, some of them might come with gastroenteritis, some of them come with cholera. These actually condition happens, therefore isolation room with dedicated facilities are really required. Even if the place is not provided with everything, at least cleaning and disinfection of the exposed surfaces should be done in a way that will keep the environment of the place properly sanitized. And at the same time, when the delivery happened, that you want to make sure that the baby will discharge without any complications, including infection. Next slide, please. One of the items actually that will also contribute infection development is actually the instrument, and instrument care is very important. In some countries, of course, there will be no enough supply of the instrument, but an instrument actually usually going to be used as a multiple use item. So multiple use instrument should be cleaned and disinfected or sterilized based on the approved protocols, and it depends on the type of the instrument and how it actually can be used. So if it is surgical instrument and going to be involved in some of sterile tissues, then they should be sterilized. If they are just going to be involved or touch some of the mucosal surfaces, then they need to be disinfected. So this is very important that staff should be aware about the instrument that's going to be used on mothers. One of the actually instrument that a lot of people don't really bother about it because they are not invasive is actually the ultrasound probes. And it is important that they must be cleaned and disinfected between the patients. We have to make sure that the gel that used is not actually contaminated by keeping it in a safe place. There's many studies that indicate that different no, can we stay in the slide, please? Many hospitals had their gel contaminated by some of the bacteria that actually can live in the environment, like Pseudomonas, like Stenotrophomonas. So they can be a risk to the mothers. One of the other problems that is actually using the vaginal probes. Also, they can actually be a risk of infection, especially if they were not covered with a condom between the mothers. And gloves actually should not be used to cover the probe, the vaginal probe, because gloves, they are not sterile to be used, and you don't want to introduce any foreign material inside the body of the mother when they are actually susceptible and they are about to deliver. So staff who are dealing with patients must be aware about the concept of the items that you use, especially if these items are single-use items. So single-use items should only be single-use, and they should not be cleaned again between the patient, because they actually were made to be for single use. And if we attempt to clean them or disinfect them, what will happen, it will affect the component of them, and some of these components will become toxic and maybe will be dropped inside the body of the patient. The other thing is personal protection equipment, which are very essential to be used by the staff who look after the mothers and their baby, and that is very important for their own protection and of course for the other patient protection. So let's go to the next slide, please. Ms. Samia, if you want to take over?
So this slide, it's a quick question we integrated on the webinar that we are encouraging our attendees to actively participate, to engage. So the question is, do you think the structure of delivery suits will contribute in infection development? No, sure, not sure, maybe. Please select the answer that you see it's correct, and we will reflect the percentage in a few seconds.
Okay, I think everybody contributed. So sure, yes, it is sure. And of course, when we say the structure of the delivery, we mean the whole area. If it was not built and provided with all the instruments and items that actually make that delivery safe, it will contribute. And there is many literature that indicate that some of the environmental pathogens can play a role in causing infection in mothers, especially if the delivery suite was actually not constructed as it should be. Okay, thank you. So we carry on. Okay, shall we remove this little box, Samia, please? The polls.
It is removed, Doctor.
Okay, all right. So so let's talk now about the mother. And the first thing that we must talk about is actually the immunity and disease. And it's very important to have a clear idea about the patient underlying condition pre-admission in your scheduled cases. Of course, that will be different when you have emergency cases, but when you have a scheduled cases, it is important that actually you know the underlying condition of the patient, and that will help a lot in managing your patient and prevent the transmission of different microorganisms to a newborn. Some condition actually could affect the pregnancy or the health status of the mother or the fetus, where the intervention required to improve the outcome, such as, for example, if the mother overall health or nutrition is not proper, or if she is a diabetic, and especially if she's not taking care of her diabetes. So these are conditions which actually be a risky on the mother life, which might lead to mortality, and also can affect the fetus life. Also, it's very important to know if the mother is actually vaccinated, how is her immunization status in general, if she is actually immunized, if she was exposed to some infectious disease, or if she's not. This is very important to know what kind of patient you have. Screening for some of the blood-borne viruses is very important, like hepatitis B surface antigen, hepatitis C, and HIV is really essential, because this actually will help a lot to protect the newborn. If she's actually positive to one of these viruses, then there is some regulation we have to apply. At the same time, as a healthcare provider, you want to make sure that you are not at risk of having any infection from the mother. So some ladies might actually come also with some STD diseases. So screening for sexually transmitted diseases, especially if the mother is actually coming from an area where she's considered as an exposed, is very important, because usually some of these diseases can be transmitted to newborn, and they can affect their life heavily. So it's important that we screen the patients for these diseases, especially if we actually suspected some of them might have that. Next slide, please. So continuing talking about mothers and their condition, some patients actually might have some type of bacteria that could lead to some severe complication, And there is, and the most actually of them, of course, is multi-drug resistance bacteria. I think we jumped a slide. Can we go back? Yeah. What I wanted to talk about is actually one of the known bacteria, which is group B Streptococci, or what we call it, Streptococci agalactia. It is one of the most known organisms that cause early onset neonatal meningitis, and also very known in causing onset neonatal sepsis that can usually transmitted to newborn. And if the mother is colonized with this organism, she might actually end up having bacteremia, endometritis, urinary tract infection, chromonomonitis, different conditions that can actually contribute if the mother is having group B streptococci. Also, if the pregnancy was less than 37 weeks, if the lady had a fever above 37 during labor, if the mother were stayed in the hospital for a long, prolonged time after her membrane was ruptured, or if she was actually living far from the hospital and she needs some time to arrive and her membrane was ruptured, and that actually stayed in that condition before arriving to the hospital, that took her around between 12 to 18 hours. These are all factors can actually contribute in development of different complications regarding the presence of gram-positive cocci, which is Streptococci agalactia. So positive screening is actually very important for this bacteria during pregnancy, unless the patient was planned for C-section delivery. So in that case, there is no need for screening, but that is if planning was put in advance before delivery, like 4-6 months before delivery, for any other medical condition that the mother cannot deliver as a vaginal delivery, so then there is no need for screening. But if the mother is going to actually have normal delivery, then screening, and that screening should be usually done in vagina and rectum at the same time to make sure that the mother is free from this organism. Next slide, please. Other diseases, as I said, include the possibility of the presence of multi-drug resistance bacteria. And this is also a very major problem, because some of the bacteria like methicillin-resistant Staphylococcus aureus or vancomycin-resistant enterococci, or other gram-negative like Klebsiella pneumoniae, or even multi-drug resistance E. coli, all actually can be a problematic, which we consider under the MDRO, or multi-drug resistance organism. And these can actually be known from either previous admission or the history of the patient as a result of admission. And of course, there is a list of many different organisms, bacterial disease and viral disease, that should be known by the treating physician, which we cannot present them all in here. But I will just highlight some of the important ones. And as I said, the multi-drug resistance organism as a bacterial organism, some of the viruses, like for example, CMV is one of the serious infection viruses that can lead to severe infection in newborn, and also herpes as well. And screening for them is actually can happen through the presence of the IgM antibody in the blood. And the herpes also, which is from the same group, can also lead to some serious complication. So if the lady have any suspicion of skin herpes, this also need to be examined. We have to make sure that the mother is not positive for herpes, because there is many other diseases can appear very similar to herpes, so need to be examined to make sure that there is no possibility of transmission. If the mother have herpes, we want to make sure that there is no possibility of transmission, because if actually the mother had herpes either type 1 or type 2, if she had a normal delivery and the baby or the newborn actually picked up that virus, it is very risky, and it can actually lead to some severe complication like damaging the liver of the baby. So next slide, please. So, of course, since the mother and her newborn will be in healthcare institution, so they can actually be at risk of having infection, and this infection can actually happen as a result of exposure to different risk factors. And one of these risk factors is actually the steroid use, and which can actually be used for other medical conditions. So if the mother is actually exposed to that, that will actually decrease her immunity and make her more susceptible to develop infection. If she has uncontrolled diabetic, and that we talked about it already, if the neutral status, either the mother is a low weight or she's obese, these all factors can actually increase the risk of infection. If the mother are coming from low socioeconomic status, and of course, usually this has a relation with the nutrition and the style of life she actually went through until she became a mother. And especially in some villages, usually the ladies get married when they're young and they are not healthy enough to carry a baby. So the whole condition, the baby will not actually be taking the required nutrition during his growing in her womb. So that also will affect. If the mother is a smoker, and especially in C-section operation, if she's going to have a C-section operation, usually smoking will affect the healing of the wound and might actually predispose her to infection. Urinary tract infection, especially when there is a preterm labor, that can actually predispose her to neurosepsis. So as a result of the presence of different bacteria, usually colonizing from the hair rectum, that can actually lead to UTI. Next slide, please. Also, other factors associated with the infection development is having a mother with an infection on admission. So if she come with an infection on other side, or even colonization with MDRO, one of the multi-drug resistance, it's very easy that she will develop infection with the same organism. Like if she's going to have a cesarean section operation and she had a colonization with MRSA, usually that colonization will lead to infection, and that infection usually happen postpartum after her delivery. If she had a ruptured membrane, which can be is either as a cause of infection or as a consequences for the condition, both can actually put her at risk of infection. Preterm labor, as we mentioned before, long stay in the hospital before operation. And one of the very important things that a lot of junior doctors don't really care about is multiple vaginal examination when she's about to start labor, especially in her first delivery. Usually it takes time, and sometimes if the doctor who's looking for the mother actually is new, sometimes they become stressed and they keep examining the lady every now and then, and this multiple vaginal examination will actually increase the risk of infection that can be developed inside the hospital. C-section operation, also it is actually one of the risk factors. We know even if it was planned, even if it was emergency, usually emergency C-section operation will have a higher risk of infection post-operation, because usually it happened in a rush, and sometimes there will be no time to apply all the basic principles of infection prevention when there is a complication and you just want to make sure that you want to save the patient's life and the newborn life. There is high risk of infection with C-section. If you have a poor skilled staff in infection prevention, like if you have a new graduates, nurses, or even doctors, and they are not really well oriented about looking after pregnant ladies, or if they were actually working at a night shift or late shift, sometimes they don't have the right skills to actually look after a susceptible mother. Busy hospital or center with many pregnant ladies. And this also happened because when there is a lot of ladies in all going to labor at the same night, at the same day, in a small place, usually a lot of doctors and nurses will panic, and they become exhausted, and of course they will not take all the required precautions as it should be. Next slide, please. One of the known thing or known infection is urinary tract infection, and as I said, it can happen in the ladies who come for a delivery, and especially if they were catheterized. And there is other factors that can actually contribute with that in development of UTI, which include that if the mother had a past UTI, or if she had a frequent UTI, especially if she's above 45. Usually in this age group, they have a frequent UTI when they are actually pregnant. If the lady actually showed up with bacteriuria, which means that there is a bacteria presence in the urine, but there is no sign and symptoms, this number of bacteria can actually multiply and cause a UTI. If the lady was actually catheterized for a long time, sometimes she actually will develop infection post-catheterization. If the mother have a kidney stones, again, usually a lot of mothers do not actually drink a lot of water during pregnancy, and that, especially if they have stones or they have the ability to form stones, they can actually have frequent UTI, frequent episodes of UTI. An operative delivery with forceps or vacuum extraction, very, very similar, and both can put the mother at the risk of infection. Then the epidural anesthesia. Many ladies had actually retention, urine retention after the use of epidural anesthesia, and that actually can last for some time, and that will actually predispose her to develop UTI. Okay, next slide, please, Samia.
So again, we'd like the audience to answer true or false. Screening mothers to group B Streptococci is very useful to prevent postnatal infection newborns. A few seconds and we will show the result. And Dr. Halwani, you can comment immediately.
Okay. Okay, very good. So everybody is actually still awake with us. And yes, it's very important that we screen the mother to group B Streptococci, because it is actually very pathogenic organism can lead to different complications. So we carry on. Thank you very much. Next slide, please. So now let's talk about the mothers. So mothers will have a lot of complications, and one of them is actually endometritis. Endometritis is actually the most known infection that can happen to pregnant ladies. And of course, it can happen either to ladies who have vaginal deliveries or ladies who have cesarean section deliveries. So usually the rate in ladies who have vaginal deliveries is actually less when we compare it to cesarean section deliveries. Endometritis is usually considered as a nosocomial, and we usually report it in the surveillance system that we do in the hospital, unless the amniotic fluid was infected at the time of admission. So it's like an infection on admission. So if there is an infection on admission and it's related to the same site, usually it's not considered a nosocomial one. But if the patient was admitted, then after 48 hours after the rupture of the membrane, then endometritis is considered a nosocomial. And it can be actually identified in the hospital in the following criteria, which are actually used by the CDC. If the patient has organism that cultured from the fluid or tissue from the endometrium obtained during surgical operation by needle aspiration or by brush biopsy. So that actually will be considered endometritis, or if the patient had at least 2 of the following signs or symptoms with no other recognized cause. So there is no other infection in any other site, but the mother starts showing fever and abdominal pain, or tenderness in the uterine, or drainage that going out from prolonged drainage from the uterus, that will be considered actually as endometritis, and she should be treated immediately. Next slide, please. So one of the known complication as well, when the mother actually exposed to cesarean section, is of course surgical site infection, and usually around 20% of the pregnancies end up with cesarean section operation. Of course, as I said, either a planned or emergency, and therefore postpartum infection following cesarean section delivery is expected. And of course, there is planned cesarean section, which usually have a better condition because it's planned, and usually the risk is lower. But when it's emergencies, it is actually contain higher risk. Prophylactic antibiotics should be selected carefully when we want to do cesarean section, and that should actually applied based on the policy of the hospital. So when we say prophylactic antibiotics, that means the antibiotics that should be given to the patient before the operation. That should not include antibiotics that given after the operation. So anything that given after the operation, it will not be considered as a prophylactic. Prophylactic antibiotics should be given before the operation to protect the tissues from acquiring any infection. So it must be noted as well that the post-cesarean infection can occur with actually 30 days postpartum. Therefore, it is very important that if any infection that identified within that period is considered. Unfortunately, what happened is actually many patients do not come back to the hospital after they leave the hospital. And usually with cesarean section in the regular condition, usually the patient take between 5 to 7 days to stay in the hospital, and sometimes even within the third or fourth day they can leave. But if the infection happened, which usually happened between the 9th day to the 12th, in most of the cases, they do not come back to the hospital. So we don't really know if the patient who delivered in the hospital by cesarean section developed infection after that. So that's why it's important that we instruct the patient to come back if she actually developed any infection post-cesarean section, because that is actually considered hospital-acquired infection. In a study that actually I was involved in, we found that around 26% of cesarean section infection were missed during regular surveillance, because a lot of patients were not identified by using post-discharge surveillance. So post-discharge surveillance is very important. That can be used, and we can pick up some of the cases we actually missed. So there is many ways in the way how you do post-discharge surveillances. There's either by phone, by filling a link, and by applying through email. There is many ways. If you search the literature, you will find a lot of ways where you can actually do a post-discharge surveillance, and this actually very useful, and you can know the real estimate of your infections in your hospital. Okay, next slide, please. So finally, let's talk about the baby or the newborn care. As you know, it is actually very important as well. And after delivery, the baby usually have a very sensitive skin, and they are very sensitive. Skin can actually, if they were exposed to anything hot or cold, that can affect the skin. But at the same time, we want to make sure that they are kept clean after delivery. So we actually recommend that cleaning the body by sterile cotton sponges that's soaked in a warm water may be actually very helpful in remove some of the blood and some of the remains that actually were on the baby. We need to make sure that if we want to use incubator or bed warmers, that these basins must be cleaned between the newborns, though they should not actually be cleaned while the newborn inside them, because actually they can get exposed to the disinfectant, and that usually can be very hard on them. If the mother actually having any diseases like open TB or like gastroenteritis, we cannot actually keep the baby with the mother. So the mother should actually be separated from the baby until she's actually better. In case she have an abscess, usually she cannot breastfeed the baby, because usually there is a risk of contamination of the milk with the bacteria that actually available in the abscess, and the abscess should be drained before the lady can actually start feeding. The same thing actually about separating the baby with from the mother is actually if the mother have other conditions like herpes, for example, and we have to separate the mother from the baby until the mother is completely healed. Next one. When the mother cannot actually breastfeed at that time, either because of she has the abscess, as I said, or for any other condition of this taking medication, then we have to take the milk from the mother and throw it away. But when she actually can breastfeed, even if sometimes some of the mothers, they have a time where they can actually have milk, and sometimes they don't. So we can collect milk in a sterilized bottle, and it can be actually kept inside the ward, and usually that should be collected by the nurses, and it should be collected in a special room. It should not be collected beside the patient bed. Usually there is some pumps which can be used to suck the milk from the breast, and that actually very important to be washed well and cleaned completely. And there is many studies which actually confirm that any contamination of pumping tools can actually lead to different bacteria to contaminate the milk. So milk must be collected into sterile aseptic container and then refrigerated for 8 degrees for up to 48 hours. But if we want to keep it for a longer time, it can be kept frozen to be used within 3 weeks. We can't put it for longer time than this because actually it can get contaminated, and it's very easy to have different bacteria that can cause outbreak in nurseries as a result of contamination of the breast milk. Next slide, please. For the mothers who cannot actually breastfeed, powdered formulas can be used, and especially if the mother are not actually capable to produce milk. But the thing is, with the formula, it's very important that we use aseptic techniques away from the bedside, and it's very easy that milk to be actually contaminated. And where it's saved, hand hygiene is very important when we deal with that powder milk, and we have to take care with every step of preparation that we do to prevent the introduction of microbial contamination. And very important that we label that bottle whenever we open it, but when it's actually can be discarded. A very important thing that when we prepare that milk, we have to use boiling water only, and it should not be tap water. There is no, this option is not accepted. In fact, actually, it can lead to a lot of complications. And one of the studies that I was involved in, that when a mother prepared the powdered milk from a tap water, which was not hot. She just used the warm water, which end up with meningitis with a special type of multi-drug resistance salmonella. Okay, next slide. Sami, you take this one.
Okay, so we would like the audience, we're going to post the question and answer again. You just click on the answer. When the mother has a breast abscess, she can breastfeed the baby carefully. She can never breastfeed her baby in her lifetime. Can breastfeed the baby 48 hours after draining the abscess. Should not breastfeed the baby if bacteria is causing if the bacteria is causing the abscess is a multi-drug resistant organism. In a few seconds, we can end the poll. You can see Dr. Halani mostly selected option C, that she can breastfeed the baby 48 hours after draining the abscess. For your comment.
All right, that's right. Thank you very much. Happy that everybody was concentrating. So next slide, please. And it is the last slide. So in conclusion, it is a big topic actually. So the mother and newborn must always be considered as one when we're managing their care, because the health and intervention of the woman will affect the outcome of a newborn. The healthcare team must work hard to prevent any related infection that might develop based on the mother condition on admission that might lead to complication that might lead to death, of course. Protecting the mother and the child from infection might not be easy, but achievable if care was taken based on the approved policies and procedures. And precise communication between the obstetrical team, the pediatric team, and the family is essential so that the necessary intervention can be taken when indicated immediately. And finally, when all these precautions are taken, morbidity and mortality will be controlled. Thank you very much, everybody, and I am happy to take questions if you have.
Thank you very much for your valuable information and time to share your knowledge and experience, Dr. Halwani. I would like to ask the attendees to start posting their answers and their questions, at the question and answer icon. And if you have a question and you would like to participate with us, we can unmute your mic. So if you have a question, you can raise your hand. and we will unmute so you can ask question directly. So we have Fatma Tuhri, she's raising her hand. Hiba, can we unmute Ms. Fatma to ask her question? Ms. Fatma Tuhri, if you have a question, you can just unmute your mic and ask immediately. So, Dr. Halwani, we have a question we received a question, can the mother take the vaccine while she's breastfeeding? Especially considering, now the pandemic since 2 years, and, this is the most and definitely most frequent question that you are receiving.
Yes, you can. There is no contraindication with taking the vaccine with pregnancy. There is a lot of rumors happened at the beginning of the vaccine, saying that if she's pregnant within 3 months of her pregnancy, that there is a risk of miscarriages, and that was not true, as few studies proved against that. So she can take the vaccine, and it's actually better and safer for her to take the vaccine.
Well, thank you, Dr. Halwani. We have Ayman Harris. You can unmute your mic and talk and ask your question. Please, if you don't have a question to ask, just don't raise your hand on the list. Samira Khaldi. So, Dr. Halwani, we would like to ask in conclusion and to sum up the whole webinar, what is the take-home messages that you would like the attendees and healthcare providers at the hospitals to take back with them and to keep in mind while dealing and treating with pregnant mothers who's suspected of having infection?
So the main message actually is looking after the mother from admission, and knowing what is the condition, her condition, any underlying condition that she might have, if she's diabetic, if she's overweight, if she have any infectious diseases. These 3 things are very important. Actually, this will help a lot in prevent any complications that might happen to the mother and to the newborn.
Thank you so much, Dr. Halwani. We are almost finishing our webinar. We have another question we will take, then we will conclude and finish. What is your advice for safe birth in LMIC, a low middle income country with very little resources, from Mr. Anas?
Sorry, I didn't hear.
What is your advice to have a safe birth in low middle income countries with a very little resources? Yeah,
it's actually a very critical question. It's not easy to apply everything, but we have to do our best. I think the most important thing, just we can make sure that we have sterile instruments to be used. This is the main thing that we can look at, because instruments, especially if the mother is going to have a cesarean section, we just have to make sure that the place is actually as clean as possible. I can't say that it should be a proper delivery suite, but we can say that it's as clean as possible, and we just have to make sure that the instruments that are actually used are sterile and it's not used on without sterilization.
Thank you, Dr. Halwani. We can see the last question from Wa'il Sarhan. I believe, Mr. Wa'il, we answered the question about the COVID and the vaccine and pregnancy. Dr. Halwani, in just a minute, he answered it's completely safe for a pregnant woman to take the vaccines And if you are asking about COVID, the answer is yes. We are reaching the time, and by this we would like to thank you again, Dr. Halwani, for your informative lecture and for your time. Dear participants, thank you for your attendance and time. And we here at SPSC and with Dr. Halwani encourages everyone to continue their work toward patient safety initiatives and movement in general, and in particular for safe maternal and newborn healthcare. See you soon on our next webinar. Thank you all again and have a good night.
Thank you. Thank you. Bye.